Immune thrombocytopenia purpura, or ITP, is characterized as a platelet count of 150,000 or less, and in severe cases, 50,000 or less. This diagnosis has been or is now secondary to COVID 19, and it has been an eye opener for many in the healthcare industry. COVID 19 is a virus that has impacted the world now for 2 years, and it initially wreaked havoc on the respiratory system and the GI system. And the CDC then added blue fingers and toes for children, and in 20-year-olds, complications dealing with the cardiac system. For hematology, side effects appeared after that and mainly consisted of pulmonary embolism, or a PE. The clinical problem: will treatments work for ITP with COVID patients? And will hospital stays increase due to this issue? Basically, in middle aged and older adults who develop severe ITP secondary to the novel coronavirus, how effective is IVIG therapy compared to giving rituximab or Nplate in combination with steroids as the first line treatment to control growth and maturity of platelets during an ITP episode? The research combining both these topics are very slim, partly due to the fact that COVID is a new phenomenon. However, there is research evolving that deviates from the traditional algorithm of ITP therapy. And that algorithm for first line treatment is the dexamethasone and IVIG therapy and platelets if needed. Second line therapy is the rituximab or the Nplate therapy. And lastly, a splenectomy. Other research shows that both men and women have been diagnosed with ITP secondary to COVID. And 20-year-olds also have been diagnosed. However, in a systematic review, it states that 70% of those surveyed are middle aged and older adults. Now, med surg is typically where these patients are going to be admitted from the emergency department with this diagnosis. And IVIG therapy is a treatment course that usually takes days to infuse because there's a certain amount of dosage that you get each day. Now, depending on the patient's sensitivity, the rate of infusion may be slowed down due to irritability, and that would also increase patient stay in the hospital. Cost is very similar to both first line and second line therapies, but rituximab has been proven to have lasting results than IVIG when administered early, meaning no relapse of ITP. In order to operationalize a new practice, this will actually start with the doctors because they are primarily the ones who have a larger part with the change in COVID practice due to how they want to administer treatment. Now, this would involve them deciding who is eligible to break the standard of ITP therapy. Eligibility can be approved if the patient meets specific criteria. One, a diagnosis of severe ITP, meaning that their platelet count is going to be 50 or less. Two, their health status. Three, personal and social obligations, school, work, household responsibilities, things that will take the parent or the adult away from the household that may affect how the household is ran. Um, Also, number four would be if there was a failure in previous ITP treatments, and five, to check and ask questions about recent infections or if the patient is immunocompromised. The nurse can then ask these eligibility questions, chart them, and then verbally relay the information to the doctor because time is of the essence with severe ITP, and it should be done on admission when the patient is transferred to the unit. Now, Gene Watson's caring theory and patient centered care model, I believe, would work best for overcoming barriers to implementing these or the small change on the unit because, I mean, basically, this taps into why people become doctors and nurses to care for their patients and to save their lives in any way, shape, or form. So, putting the patient in the center of their care plan is essential for curative factors of problem solving, improve health and trust with other staff, and to improve, again, the health outcomes, which has been proven with evidence based research, practice, and in theories. Time is a real factor in implementing change and not just the duration. Spending time with the patient to ask about social questions, along with the assessment and the questionnaire, will help establish who is eligible to break the regular algorithm for ITP treatment. Now, I understand this a lot because I was diagnosed with ITP secondary to COVID back in May of 2020. And I presented with all the signs and symptoms of ITP, but couldn't really understand why someone in their late 40s developed this, because this is either usually diagnosed in a young age or in older adults. And while in the hospital, I was doing some research and noticed that there was some evidence that COVID, that ITP, I'm sorry, was a side effect to COVID. And they started me out with dexamethasone and IVIG therapy. And I was one of those individuals who was sensitive to the IVIG therapy before they went on to secondary treatments. And I ended up being transferred to a different hospital so that I can get a bone marrow transplant to rule out leukemia. My entire visit was 2 weeks. And being a full time student here at Aspen University and having um, clinicals online at the time, you know, really put a damper on the situation. And thankfully, I was able to get things accomplished. So I do have some firsthand knowledge about what's going on and how patients really respond to treatments. Um, but back to the research. COVID, again, is a novel virus, and new information is continuously being developed. It will take years, though, for multiple evidence based research to emerge, especially as it relates to ITP. However, I was able to find a few articles. One was the systematic review on ITP being secondary to COVID, frequently relapsing post COVID 19 immune thrombocytopenia. And again, that involved failure of IVIG therapy. And then immune thrombocytopenia secondary to COVID. These were my main sources. And that article just helped to prove that truly um, COVID caused the ITP. Now, ethical considerations for this project is defining if the treatment plan will do more harm than good for the patient. And this is another reason why the eligibility questionnaire is very important. Of course, the patient would have to voluntarily participate in the project. Informed consent must be given, and the program manager would have to provide the patient with results about their care and provide confidentiality. Keeping the patient informed about their care is very important. Now, the evaluative process for this project is simple. Based on the number of participants, the increased number of platelet counts, and how well the patient tolerates the treatment during and post COVID infection in 10 days. And the reason why I said the 10 days is because I was in the hospital for 14 days. So to be able to cut some time down, I think would mentally help the patient as well as physically help the patient. Both subjective information from the patient um, would include their response to side effects, and objective findings from CBC lab tests will be used to identify the progress. If more than half of the participants respond well, then the possibility of using the deviated treatment regimen should be considered. It would decrease time in the hospital, especially in a time where beds are crucial, and increase health wellness. With the combination of therapy of dexamethasone, it treats both the ITP and COVID simultaneously better than IVIG therapy. And thank you very much. This was my report. Have a good evening.